Good morning. I am Dr. Andrea Anderson, and I'm a member of the FSMB Board of Directors and the chair of the DC Board of Medicine in our nation's capital. It is my great privilege to moderate this session on trends in continuing medical education. As you all are aware, guidelines and systems for CME continue to rapidly evolve in new directions here in the US, including things like innovations in interprofessional, cross-disciplinary CME, emerging competency-based models, and new approaches aimed at reducing administrative burden. In our discussion today, our panelists will discuss a variety of trends and developments underway across the country and what those trends mean to state medical boards. We've got a great panel for you, and I know you're going to enjoy it. First, we have Dr. Kathy Chappelle. She is the Senior Vice President of Accreditation, Certification, and Measurement at the Institute for Credentialing Research and Quality Management and Advanced Practice Initiatives at the American Nurses Credentialing Center. It's a mouthful.
You should have just said Kathy.
It's a mouthful. She does a lot of things. She's responsible for the certification of individual registered nurses and advanced practice registered nurses and the development of certification examinations. Dr. Chappelle is also responsible for the accreditation of organizations that provide continuing nursing education and interprofessional continuing education and for accreditation of residency and fellowship programs for nurses. Finally, she directs the Institute for Credentialing Research, analyzing outcomes related to credentialing and the Quality Management Development Department. Welcome, Dr. Chappelle.
Thank you.
We have we're going to skip one, Mr. Tom Granatier is the Senior Vice President of Policy and External Relations for the American Board of Medical Specialties, the ABMS. In this role, he is responsible for state and federal policy development and strategic relationships in the private and public sector. Mr. Granatier has more than 25 years of experience working in health policy with a particular focus on quality and public accountability. He has worked in mental health policy for the state of Illinois, hospital policy for the American Hospital Association and the Health Research and Educational Trust and the Joint Commission, and finally, long-term care policy for the Health and Medicine Policy Research Group and in public policy and health policy for Humana Incorporated. Welcome, Mr. Granatier. Finally, in the middle, we have Dr. Graham Mcmahon, President and CEO of the Accreditation Council for Continuing Medical Education, and fresh off their annual meetings that ended just yesterday. In this role, Dr. Mcmahon leads efforts to leverage the power of accredited CME to address national and international healthcare challenges, including improving physician competence and performance and contributing to healthcare improvements for patients and their communities. In collaboration with the ACCME's governance, he oversees initiatives to fulfill the ACCME's mission and vision by setting standards for education that accelerate learning, change, and growth in healthcare, and by sustaining a framework that supports, inspires, and motivates educators to achieve their full potential. Dr. Mcmahon also serves as an endocrinologist in practice at the Howard Brown Health in Chicago and is an adjunct professor of medicine and medical education at Northwestern University. So welcome. So we will have the panelists give a short presentation and then we'll open it up to your questions. So we'll start with Dr. Mcmahon.
Good morning, everybody. Really nice to see you all here. I was flying in last night and they were telling me that everyone was asking me, are you going to Jazz Fest? So you're all here despite Jazz Fest. So thank you for hanging out with us and talking about something that's near and dear to my heart of continuing education and education in general. I'll say a few words, as Andrea said, about our system, what's happening. We'll have a conversation that Andrea has some questions for us, and then I look forward to your questions and how we can be of better service to the state medical boards, how we can work together more seamlessly and more effectively, and drive the change and improvement that we need in our profession. So a couple of things I thought I would tell you about. Not all of you know ACCME very well. You've probably heard a little bit about us, but don't know much about us. So I'll say a few words about that. I'll say what we know about the value of continuing education and continuing professional development, what the data tells us about what's been happening recently in this whole sphere and world, how you can use data that's in our systems to help you make licensing decisions more accurately, and then some things about our collaborations around opioids and other issues internationally and domestically, where CME is going. And then we'll pass it on to Kathy and Tom to share their perspectives, and we'll open up for questions. All right, so these slides are all in your app, so if you have trouble reading from all the way back there, I understand you can open up your app and follow along on there. But I will say ACCME has a vision and a mission, and our vision is a world where our community of educators supports clinicians in delivering optimal healthcare for all. And that's not an unintentional vision. It's based on a mission that assures and advances quality learning for healthcare professionals that drives improvements in patient care. And what's interesting here is that we're not fully talking about information transfer anymore. We're talking about skill development that drives performance improvement and the ability of clinicians to practice at the top of their art. ACCME is a collaborator, of course, with FSMB, who is one of our founding organizations, with the 6 other organizations that are our member organizations that contribute leadership and vision and insight to us. But increasingly, FSMB, under Hank's leadership, have been a core collaborating partner with us, and I thank you and your community and Hank for that. So what does ACCME do, and how do we meet our mission? Well, we set standards for continuing education. We perform audits and surveys of the organizations that we accredit to make sure they're following the rules. We support and educate CME providers. As Dr. Anderson mentioned, I just came from our 3-day meeting in Chicago where we're building skills of educators to deliver better educational programs. We produce reports, and we are always changing and evolving to support the community's needs. And our core value proposition is we're giving clinicians and physicians the reassurance that the education they're participating in is balanced and evidence-based, is designed for real needs and gaps, not somebody else's or for some marketing. They're evaluated to guide safe and effective care, and they're free of commercial influence and marketing. Those are the core principles on which accreditation and accredited continuing education rest. So what are some of the specific things that we do? Well, we certainly set standards for continuing medical education. What works, what matters, what kind of educational formats and approaches are appropriate to be able to be associated with the credit. We accredit new providers through a rigorous process to make sure they can jump over the bar and meet those standards. We manage an accountability system for accredited providers, so we perform audits. We have committees that evaluate and review organizations to ensure they're following the rules. We evaluate content validity, for example, when there are complaints or concerns about valid material. We manage and share data about the system, we educate, and we continuously evolve, as I mentioned. So what about our Criterion Standards? What should you know about what ACCME expects of educational providers? We operate what we call a trust and verify approach to accreditation, meaning that you have to reach a high bar to get accredited as an organization. If you're the University of Texas, you have to show us you can do our work and follow our rules. You'll get provisional accreditation, and then you'll be able to go and do your work, and you can plan activities same day, produce activities based on a need in your community, in your hospital, in your facility, and then we come and look at you retrospectively, periodically, to make sure you're following those rules. But there are a variety of rules here. Accreditation requires that you design education to meet real needs, that you analyze the change that comes from attending programs and engaging in them, and that your system continuously improves. But of course, we also now have standards for integrity and independence that have been around since the early 1980s, including valid content. You can't present material in accredited continuing education that is not evidence-based. We saw a lot of these challenges during COVID, of course, in trying to manage educational content for accuracy. But you also have to manage the financial relationships of faculty and planners, manage commercial support correctly, and manage the rest of the ancillary activities. But we also operate an incentive system to try and drive educational providers to higher levels of performance with our commendation criteria. And these are optional criteria that reflect best practices in educational delivery that we pull organizations towards. So having achieved accreditation with ACCME, educational providers can issue an unlimited amount of the AMA Category 1 credit for their activities, which is used, as you know, as a common currency for credentialing, certification, and licensing in the United States, and is recognized in many other countries as the gold standard for an accredited provider. Accredited providers have to deliver effective training and learning experiences, and interestingly and importantly, retain details about all of their activities for audit, and list their activities in our data systems. And then we have those data systems available for physicians and state medical boards, for example, through our CME passport system, so people can find them. So what about this value proposition? Well, I'm a practicing clinician. My clinic is absolutely crazy. I work in an FQHC that operates on heart, and it's a really challenging work environment. And all of our licensees work in very challenging work environments, especially recently. Family expectations of balancing professional and personal lives are bigger than they've ever been and challenging. The administrative burden of practicing is enormous. There are huge productivity expectations. The difficulty and complexity of the work is advancing in ways they've never been before. And patients expect enormous amounts from us, both in communications and the quality of what we deliver. And you can imagine in that context, it would be very easy to say, the last thing I have time for is my own professional development. But it's the thing that you almost need the most in these very challenging circumstances. And part of the challenge is that each of us has an enormous array of competencies that make us effective physicians. They are scores, if not hundreds, of individual competencies. Things like you have to be able to type, you have to be able to talk to people, you have to be able to be self-aware to some degree, you have to be able to understand how to prescribe, you have to be able to know what the right medicine is to prescribe, to diagnose, just the hundreds and hundreds of skills that come from being a practicing clinician. And each of us can't possibly be perfect in all of those skills. So not only is there always a changing environment of insight and ability and expectations, but there's also a wide range of abilities amongst our professionals to function effectively across these hundreds and hundreds of ranges of performances. You mix into that the fact that most learners don't know what they don't know. Well, in fact, every learner doesn't know what they don't know. And they don't know what they need. If you think there's only 3 medicines for asthma, and somebody says to you, do you provide good asthma care? You say, well, I use my 3 medicines. Of course I provide good asthma care. You may not be aware that there's hundreds of medicines, well, not hundreds, but so many medicines to provide effective care or better approaches that you may not even be aware of. So it's easy to be self-satisfied and believe you're learning, and it's easy to be self-satisfied and overconfident in your skills because you get very little feedback, even when you're performing at a relatively rudimentary level. And in education, it's really challenging because even in educational programs, you come to an activity, people about heart failure or something, people are talking about heart failure, you're hearing lots of familiar words, and you believe that you are learning because you're in a comfortable, safe environment with lots of familiar terms going around, and you're doing anything but. So the challenge is evolving educational strategy so that we're building on skills that are really needed and actually training our professionals in the limited time that we have them to make real learning advances and make a difference. So we have these challenges of absence of feedback, lots of competing demands, pride in the profession and professional ability and overconfidence for professionals that leads to these challenges of complacency, suboptimal performance, and errors. And that is enormously challenging for us as a community because we're never going to improve and help physicians practice at the top of their art unless we address them. The last few years have seen enormous changes. The move to online education was accelerated by the pandemic. There's been much more engagement in participatory education, but physicians seem pretty averse to engaging in activities that have high cognitive load. If you're very used to learning passively, and now I put you in an activity that's much more engaging but much more challenging for you to engage with, a lot of physicians find that a challenge for them, particularly if all they're doing is, I want to do something while I'm eating my lunch, and now you're saying, here's a very complex problem to solve with 3 of your classmates or co-workers. It's a real challenge for us. The good news is that we know that education works. We know we can create highly effective and functional and enjoyable educational programs. If you combine assessment and feedback, training, continuing education, and a facilitating environment, you can create performance. And that's what we as a community and as a profession really need. But it's not just the performance of individuals that benefits from engagement in education. Education contributes, of course, to the performance improvement that drives patient safety, aligns with best practices, but also stimulates the type of intellectual growth, the building of teams, and using the facilitating function of education to bring people together to create community. Those are really powerful things to improve an individual's sense of satisfaction, the retention in the workplace, and reducing things like burnout. So this is not just about credit seeking. Continuing education is about professional fulfillment and advancing the community to meet the expectations that we have of them, they have of themselves, and drive us all to a higher level of performance together. COVID was uniquely challenging to our community. We saw enormous staff changes, new technology, this evolution towards online learning and virtual meetings, and a whole range of new content coverages that we had to address and manage in our system. Cross-training physicians to perform new tasks, building teams in difficult circumstances, deploying telehealth expertise, trying to drive self-learning behavior, self-care behavior, and addressing the unique challenges of diversity and equity and inequity and racism in our community too. So what does the data tell us? Well, we accredit 1,680 different organizations in the United States and around the world, the majority of whom are healthcare and hospital systems, but also over 300 medical societies, publishing organizations, like the big journals, about 152, schools of medicine, 150, 33 in the government and military, and then a range of other organizations, including insurance and managed care organizations that use education to drive improvements in clinician performance. But all of them are beholden to ACCME's expectations for quality. Of those 1,680 providers, they produce about 170,000 activities in 2020, over 1 million hours of instruction, leading to at least 18 million interactions with physicians, and 27 million interactions with non-physician healthcare professionals. Very interesting how that has changed, and Kathy and I will almost certainly talk about team-based learning later on, generating about $2.2 billion in revenue, and 9% of activities received any grants from industry. That's way down over the last few years progressively as we've installed increasingly strict rules around what activities can be funded and under what circumstances. But the trends are also clear about what happened during COVID in terms of the range of activities, but they're really interesting. This very top line is the hours of instruction. And you see that top line in 2019 get up to 1.35 million hours of instruction, and decline to just over 1 million the following year. And that was a big decline in the hours of instruction available. But then you look at the red line and the green line, those are physicians engaging in those activities, and the numbers are at record levels. And you look at the green line, the number of non-physician engagements in continuing education, you see record levels of engagement that are just incredible in terms of how much of our community were learning and engaged in their own professional development during the pandemic. And I won't go through these in much detail, but we've been tracking which types of activities have been changing over time. And not surprisingly, live courses saw big declines. Enduring activities tended to do pretty well and persist. But internet live activities up fourfold, 370% over that period of time. And we're seeing similar trends in the data in 2021. Hours of instruction, obviously contraction in the number of courses, but enduring activities up, and course hours overall down by 56%. And here, record level of engagement by physicians, including internet searching and learning activities based on data sets, and overall engagement by non-physicians up by over 40%, 7.3 million additional interactions. What's interesting about having all of this data that we set up is that we can now make it available to state licensing boards and state medical boards. And as one of the things that I hope you'll take away from today's conversation is the opportunity to do what several of your colleagues, state medical boards, are doing, and use this system to track your own learner completion data and verify CME credit completions in your state. So CME has gone digital. Licensing boards now have access to fully digitized information about our accredited educational providers, their educational activities, and the physicians who complete them. So those of you in the room who are physicians almost certainly already have your data being tracked in the system for you, and you should go to cmepassport.org and start seeing what's in the data system for you. But over the next few years, you'll see that data gradually increase progressively and be able to be used for research, but also for making licensing determinations a whole lot easier based on readily available and free CME information. So we have data in the system not just about the educational provider, but all about all the activities they produce, and now about the learners who've completed each of those activities in one central repository. So what happens in the system? Well, the physician registers for an activity with the accredited provider who has obligated to list that upcoming activity in our system. That goes into our data system, and as the learner completes it, then the learner is linked to that activity and is made available to their state licensing authority, their certifying board, and also in a personal transcript for sharing if desired. The system that physicians use is called cmepassport.org. And we haven't yet been marketing that to physicians, so most physicians will never have heard of it. And we won't be marketing it particularly because there's no fee for this service. It's completely free. And it's essentially just digitizing all of those PDF CME completion certificates that you all used to get. We're essentially just digitizing all of that information now so that it's all available in one central repository for everyone to use to make audits and CME verification much easier. So a variety of the big certifying boards are using it. We've been tracking data for over 450,000 physicians in there. We now have several state licensing boards already using it, and we can readily manage identity matching through our data collaborations with Hank and the crew at Federation of State Medical Boards. So there's a variety of problems we're solving with this data system. We're certainly helping physicians plan their learning because they can search and find activities that meet a particular requirement through the search engine at cmepassport.org. We can eliminate a lot of the erroneous attestations that are out there. A lot of physicians are telling you they've completed their CME requirements and they've done anything but. We know that is true because we've done audits of those reports and they are routinely incorrect. Physicians will no longer need to receive or retain PDF or paper certificates because all the data will be in a centralized system. Boards don't have to count or verify certs or self-reports because they can just look and have it counted for them. Audits are easier for everyone. You don't have to even contact physicians who are selected for audit because you can just look in the system and confirm that they've fulfilled the expectations of the audit with a couple of keystrokes. We're centralizing and simplifying identity matching, so it's easy for physicians and others at the outset. And you can see insights into CME content, format, types, outcomes in one place. You want to run a report of what's happening in Texas or in North Carolina and see what kind of activities your physicians are engaged with, your licensees. Do some research. The data is there for you. Fundamentally, though, we're displacing compliance management from you at the back end to the front end, and we're doing the work for you before you ever have to look at it. So by the time you look at it, it's verified. This is a copy of the website that is used for physician-facing. This is cmepassport.org. It's a search engine. You can search by a variety of tags, state licensing expectations, or content that you're interested in, or specialty that you're in. And physicians can log in there and see their own transcripts and download and send it to anyone who needs to see it. And you can get lots of data insights from it. This is just one swipe of pediatric data, for example, showing the types and ranges of information coming from pediatrics, and the types of activities and content areas that are being studied there. But you can also see levels of outcomes being generated for the activities that are out there. So competence, performance, patient health, not just knowledge, even population health outcomes based on continuing education programs. And we're already starting to see a variety of research opportunities and reports coming from this type of data architecture that are encouraging. So a few quick words about collaborations, and then I'll pass it over to my colleagues for their comments. But happy to answer questions about CME Passport and our data systems. We also have a poster outside here so you can learn more about it. And my colleague Marcy is here as well, and we have some handouts, and happy to chat with you about those opportunities. So what about our opioids? Well, a huge issue for us as an enormous community, and we're still unfortunately dealing with this remarkable tragedy. But we have big problems. We have a big confidence-competence gap. Most prescribing physicians, or many prescribing physicians, think they know what they're doing when they're working with opioids, and often, unfortunately, do not. And this results in complacency and errors and pretty low motivation to engage in better practices in prescribing. There's no centralized way of identifying individual performance gaps because it's very difficult to identify completely incorrect opioid prescribing behaviors. And it's resulted in all sorts of problems, including ineffective use of the millions of dollars that the manufacturers are obligated to spend on education by the FDA. It's just not being used quite correctly. We've been involved with the FDA to try and solve many of these problems, but aligning regulatory requirements across the system and creating the siloization of data across the states and the different requirements just make it a very complex area to make headway. But we've been part of the National Academy of Medicine Action Collaborative on opioids and burnout and all sorts of other issues, and we have a whole variety of things going here to try and not just identify but address some of the key priorities and work with our colleagues. And there's more in the slides and in the data that's in your apps. If you have questions about what we can do, what we should do, we can address those in the Q&A. Lastly, a few quick words about the collaborations that we're doing and continuing to push on. Enormously successful cross-professional collaborations. Kathy's here from nursing, but we have fantastic collaborations with our colleagues in pharmacy and now 7 other health professions, including PAs, optometry, nutrition, social work, psychology, dentistry, and others, who all are using the standards that we're adopting together around integrity and independence in continuing education, and in things like outcome expectations and assessments, so that we've created this system called jointaccreditation.org that if you don't know about, you should pay attention to. And then those organizations that are jointly accredited can issue something called the IPCE credit that Kathy is also going to address in her comments. Terrific cross-continuum collaborations with our colleagues at ACGME and the LCME, the medical professional societies and others, and a lot of governmental and other collaborations, including internationally. So I won't push on the future of continuing education. We can address some of these things, and I have a variety of comments in the slides that might be useful for you to look at. But I defer to my colleague, Kathy Chappelle, and her presentation, and then we'll go to Tom, and then we'll open it up for further questions. Thank you very much for your attention and your time. Look forward to chatting to you further. Thanks, everybody.
Okay, thank you so much for your comments, Graham. We're going to go next to Dr. Chappelle.
You have somebody, I don't know if he wants to, do you want to take a question? Looks like somebody.
We're going to hold the questions for the end. Thank you so much, but we'll definitely get right back to you. We're going to hold the questions for the end.
All right. Thank you, and good morning to all of you. Quick question for all of you. How many of you currently track learning for maintenance of licensure by hours, by time and seat? Raise your hand. So how many of you, for maintenance of licensure, are tracking learning in hours, in time as a metric? All right, keep your hands up. How many of you think time is a measure of learning? Right. So that's one assumption that I'm going to challenge today. And the other is, how many of you are tracking for your physicians team-based learning as a condition of maintenance of licensure? 0. All right, I'm going to be telling you why you should. Both of those assumptions. So to think about why time, how we got to the point of measuring time for learning, we need to think a little bit about the continuing education system. So from a CE standpoint, professional development standpoint, first we used a competency-based apprenticeship model. So you apprenticed with another physician if you were learning to become a physician or a nurse. And then we moved into a more formalized academic model where the academic part of the program was fixed, and then you had a more competency-based residency program. And now we've moved really to a fully time-based system across the education continuum. And time, well, how do we get to time? We got to time really based on the Carnegie unit, which was never intended to be a measure of or proxy of learning. What it was a measure to validate the amount of time that a college professor spent with students for retirement purposes, for pensions. And what we did was the system used that time-based metric, that credit unit, not only in the academic programs, but that evolved then into the CE system. And globally, if CE credit is awarded, at least in medicine and nursing, it is almost always by time. So why do people like time? Well, it's easy, right? We know when you start, we know when you finish, we can add it, we can subtract it. It's got this historical context, it's equitable across a variety of different settings. But at least in nursing, and I would argue across the professions, we were continually being challenged that time is an appropriate metric, that you sitting in a seat for 8 hours meant you learned more than somebody sitting in a seat for 2 hours. And we know that that's ludicrous. People don't learn at the same rate based on time. And so this prescriptiveness, our Commission on Accreditation, which is our governing body in ANCC for continuing education, wanted to pilot a new system. And we also wanted to give credit for workplace learning and other types of activities that were really outside of what we traditionally awarded CE credit for. And we had an opportunity at ANCC to pilot this model because we own all parts of the system. So we have an accreditation system that develops standards for organizations that do continuing nursing education and collaboratively on interprofessional education. So they could develop a model to award CE credit using a different model. But if they were to develop a model and no one were to use it, it would just be a waste of time. So we are blessed that we also have a commission on certification. So we certify advanced practice nurses and nurses in specialty practice, about 280,000 certified nurses through ANCC that all need CE credit in order to maintain their certification. So if we were going to develop this different model of awarding CE not using time, our Commission on Certification said, yes, we will accept the model that you were, the type of CE credit that you were going to award towards an ANCC certified nurse. So we were able to pilot this with no risk. Well, actually, let me rephrase that, with a little risk. So we could build it and people wouldn't want to invest in it. So to Grant's point, it's easy to sit in a chair, to check the box, to get the certificate, and you got your CE credit. It is, or may be more challenging to demonstrate learning in different models And some people engage in that, and some people don't engage in that. And we didn't know if this was going to be too challenging to operationalize. Were our CE providers going to be able to develop this alternate type of credit? If they did it poorly, if we said to our CE providers, here's the model, we want you to go out and operationalize it, and they did it poorly, it would be difficult to rein that back. And we did have to develop tools and resources for organizations to do this type of credit. And we talked a lot about what should we be measuring. We don't want to measure in time and seat, so we want to measure things like the ability to apply knowledge in practice, we wanted to measure practice change, and we ultimately wanted to measure the impact on practice that clinicians who engaged in learning achieved. And that really is the foundational basis for all of our systems. That's what we want ultimately, but we wanted to get away from this time-based model. So here's the conceptual framework that we developed, and here's how we are awarding continuing education credit. So if you are a level 1, if you got credit for a level 1 activity, for example, you're able to demonstrate knowledge and skills, not in context, but just independently. But when you get up to level 2, you're applying knowledge and skills in context. So that might be through a case study or something like that. When you get to level 3, you're demonstrating that in an educational setting like simulation. So we're taking what you know in context, we're applying it in a simulated or educational setting. A level 4 activity means you actually translated that into your practice setting. And a level 5 activity means you made an impact on practice, patient, or system outcomes. So those were the levels agnostic of time. And what did we learn when our providers started doing that? What did our learners say and what did our providers say? From the learner standpoint, the ability to get credit from workplace learning was a huge positive motivator. But for some people, they were like, thanks, no, I don't want to do this. I'd rather just sit in the seat, get my certificate, and move on. So some learners needed to be voluntold, they had to participate, and others absolutely embraced it. Some of it is related to the individual and their internal motivation, and some of it's related to the setting. So if you're in a big conference, for example, you're not going to do an outcome-based credit. We're not going to say everybody can leave the room after the hour and 15 minutes, only if you pass a post-test with 5 questions. We're not going to do that in this type of setting. We're going to say an hour and 15 minutes, the session is over, you're moving on. But in some types of activities, an outcome-based credit system works wonderfully. In a practice-based setting, when you're trying to do a PRQI improvement project and you want to get credit for that, that's agnostic of time. So that would be a better strategy for a level-based credit. But those in those regulatory bodies, our Commission on Certification, had to marry the two because learners will come with a variety of different types of credit. And our Commission on Certification, or a licensing body, is going to have to figure out what is enough credit over your period of licensure or period of certification that we feel is acceptable to demonstrate learning. And so what we did was we took those levels and we developed different profiles, and we said if you only did, for example, one level 5 activity, so that is I engaged in learning, I transferred it into my practice setting, I made a difference in a patient or system outcome, that is all you would need to do for your 5-year period of certification, that what you would be required to do over the past 5 years. Because the Commission on Certification felt that is the most impactful for patient care, is for you to engage and demonstrate that level of learning. And I would argue it's much more than the hours you would have actually checked off a box, and it's much more impactful. So I'd be happy to talk afterwards for other things, but this is the table that we developed in order to have our certifying body recognize this type of credit. So now I want to move on to the interprofessional continuing education credit that's awarded through our jointly accredited providers, and Graham referenced this. So joint accreditation is a simultaneous accreditation, so any organization that's jointly accredited automatically gets the opportunity to provide continuing medical education, continuing pharmacy education, and continuing nursing education credit through this single set of standards, single structure. If an organization is jointly accredited, they have to be providing 25% of their CE interprofessionally. But they can also provide single profession education for the other 75%. And why did we do that? As accreditors, we were trying to incentivize organizations to develop team-based education. And we knew that we had multiple organizations that were accredited by all of us, and we wanted to decrease that burden. And we also, as a side, and I don't think we realized this when we first started the Joint Accreditation Program, we launched it in 2010, that we were different in our terminology across accreditors, so by aligning that, we were able to decrease the burden across the organizations that are accredited by us. So this is our definition of interprofessional continuing education when members, so not students, it's not interprofessional education, the academic side, this is really in the practice side, when members from 2 or more professions learn from, with, and about each other to enable effective collaboration and improve health outcomes. And it is not just co-locating learners. We still see organizations apply where they think that if they have multiple professions coming to their educational activities, that's interprofessional continuing education. And we would call that interprofessional registration, not interprofessional continuing education. Interprofessional continuing education means that educational activity has been developed by the professions that are representative of the target audience. And it really addresses gaps, processes, and outcomes that are relevant to all members of the healthcare team. These are the characteristics. You have to achieve an outcome that reflects skill, strategy, or performance of the healthcare team or the impact of the team on patient outcomes. And learners have to be able to engage, learn from, with, and about each other within that activity. And the evaluation has to reflect the team or the impact of the team on patient outcomes. Not the individual practitioner saying, I will change my practice as a nurse, but how it reflects as a nurse, as a member of the healthcare team. So this is the credit that we can award, that a jointly accredited provider can award. We see huge growth in the number of organizations that are applying for joint accreditation and a variety of different types of organizations that are applying. And all have been successful. You see the other, Graham mentioned the other associate accreditors. They can award multiple different types of CE credit depending on who the target audience of that jointly accredited provider is. And I want to close by saying that in 2018, the FSMB actually recognized interprofessional continuing education credit as a means of satisfying the CE requirements for medical license renewal, which was a huge boost to the program and something that we would like to see certainly operationalized wider. We do have the Georgia Board of Pharmacy now recognizes interprofessional continuing education credit towards pharmacist licensure in Georgia, and we would love to see this adopted more widely. Thank you.
Thank you so much, Dr. Chappelle. Mr. Granatier, for your comments, and then we'll open it up for discussion.
Good morning, and thank you, everybody. Thank you for letting me join you today. Page down? How about that? Did that work? Oh, okay. Here we go. Okay, I don't have any disclosures, but I don't have any important disclosures. I don't have any financial disclosures, but I do want to disclose where I'm headed. So my destination, I won't tell you about the journey. We'll talk about the details, but we think that the boards, as you know, have been changing the approach to continuing certification for the last decade, and we think that we just completed, let's just say we're at the end of the beginning and just getting started with the transformation, but we think the change is going to really have an impact on the learning landscape, and we believe there's lots of opportunity for us to collaborate with our colleagues here and with the FSMB and the medical boards. That's one of the things that I hope we're going to talk about. We have a lot of shared goals. Mark Twain once said that history doesn't repeat itself, but it does rhyme. I'm not going to repeat any of the stories that you've heard, but we are going to rhyme. This is our mission. I'm going to go through this stuff quickly because I want to leave time for your questions. We serve the public and the profession. This predated the commission that was created to re-examine our continuing certification programs, but this theme actually became an important feature of the recommendations and of our new standards. That is that we were trying to serve both aspects of our mission. We have 24 boards. They're independent. I'm sure you know that. They're fiercely independent. They certify 900, well, by count last year, close to 950,000 physicians. About 2/3 of them participating in continuing certification. We still have some non-time limited certificates out there, although they are declining. And we certify in, as you know, 40 primary specialties and 85 or 87 subspecialties. So we have adopted a new set of standards after a lengthy period of consultation. We started consulting with our communities back in 2010, actually, because the dust-up around continuing certification began around the same time that MOL policy was adopted by FSMB. And we developed some new standards in 2012, which were implemented in 2015, by which time the tsunami of antipathy towards continuing certification was beginning to reach its peak. We created a commission in 2017 of stakeholders, mostly physicians, but including public stakeholders, nurses, hospital folks as well on that commission, to provide recommendations to us, which were produced in 2019. And we created a series of task forces to help us figure out how to implement those in 2019, which finished their work last year. The main feature of this is that we have to try to meet both of our goals. Our commitment to the public is to create a credential that demonstrates to the public, that demonstrates that physicians have achieved the knowledge and skills, have demonstrated the knowledge and skills that are necessary to do the job that they have. And but to do that in a way that supports learning for the physicians. The number one complaint that we had about continuing certification is this isn't helping me to be better. And that's the number one recommendation of the commission, is figure out how to help people be better. Another major feature of the recommendations was that we have to be collaborative, and not just with our clinical community, but with the broader community of organizations that share a responsibility with us for educating and training and regulating and improving the physician workforce. So as you know, we do have an assessment. The assessment has changed. We have asked our boards to be more intentional about their assessments, to have goals for their programs and learning objectives. Some of our boards are already doing this with mixes of core content and practice-specific content. Most of the boards have ways for the diplomates to customize the content of their examinations. Many of our boards have already begun to incorporate urgent public health issues which are facing clinicians in practice. And the assessments are not all the same, but they're all designed to provide immediate feedback to clinicians to help them develop their learning plans and fill their identified knowledge gaps. Our assessments, although they are formative, are still used to create what we call a summative decision. We still have to render a judgment about whether people have the knowledge and skills that the certificate says they have, and they have found a way to do that. Of our 24 boards, 19 have adopted a program which we call Longitudinal Assessment. Some of the boards that don't yet have it, I think, will get there, but they all have ways of providing ongoing feedback to the clinicians through the assessment. But the Longitudinal Assessment specifically is a convenient online assessment with short bursts of questions, content, again, that is practice relevant, and providing immediate feedback with links to learning. We could obviously improve the way in which the feedback that the clinicians are getting about their learning and the aggregate feedback about where the knowledge gaps are across the specialty is shared with the CME community, something that I'm sure Dr. Mcmahon will remind us about when he gets a chance to comment. These programs are we've gotten very good feedback on these programs from the participating physicians, high levels of satisfaction, but not universal. And despite these changes, we still don't have a lot of folks with non-time limited certificates choosing to participate in our continuing certification program, something that our standards do say we should try to figure out how to do, which means that we haven't yet created enough value for the folks who don't have to do it, and that's something that's on our list. We still have a learning expectation that physicians are participating in education. We have an important but not fully realized recommendation from the Commission that the learning, the assessment, and the improvement components of our program need to be better integrated. This is something we think we can do by being more intentional about our goals and objectives. And we haven't fully articulated that, but that's something we are going to be working on. For the improvement component of continuing certification, something that has been controversial, we're asking our boards to aspirationally try to engage all of their clinicians in improvement work that's satisfying to them, that it solves a problem that they know that they have to solve, but also to work with their clinical communities to identify quality and safety priorities that are important. We can also say public health issues like health disparities, better understanding of social determinants, disaster preparedness, and preparation for new disease threats, the opioid crisis. There are various things that we could address here, and also health equity. And we've explored the ways in which the improvement component can be one way to be looking at practice and trying to address equity issues. Professionalism is something we spent a lot of time talking about. It's still a core element and really a prerequisite for becoming certified. We have, alongside the standards, developed a new policy on professionalism, which is going to change the nature of the relationship between our professionalism assessment and the medical board medical board discipline. We received feedback first from our commission, but then subsequently from the state medical boards. In 2017, I met with the administrators in medicine who felt that our boards were overreactive to the discipline that were received by the medical boards. We started examining our policy and have created a new policy which will go to our board in June, which will give our boards permission not to act if an issue has been disciplined by the state medical board, which our boards believe does not actually indicate a violation of professional norms. So we're anchoring our policy still with state licensure, but we are the determinations that our boards are making are going to be based on sort of twin issues of patient safety and trustworthiness. And if you want more about that, I can speak at great length about it. We also spent 2 years consulting with our community on professionalism and have some ideas about ways in which we can be more positive about professionalism. And we've also been told by our commission that we need to have a remediation opportunity so that people can resolve their performance or participation gaps and have opportunities to get recertified if they need to. So the learning landscape has changed. We think that these changes are going to provoke a dialogue with the community, the CME community. At least I hope they will, and maybe we can start that dialogue today. COVID has put a couple of big issues on our agenda, which we don't think we can avoid. The issue of competency-based assessment and education is something we've been in active dialogue with ACGME and with AAMC, and I believe it should also be something we're talking about with ACCME. We have been told that we need to promote equity, diversity, and belonging. It's on everybody's agenda. Something we cannot address unless we address it together. And we have to be collaborative, and we have to create better alignment across all of our organizations. We heard Lisa Robin in her wonderful testimony at the hearing on the opioid crisis at the Duke Center talk about the need for better alignment. There is a provision for the medical boards to provide an option that is an alignment opportunity. It's from 2012. Your House adopted a policy that the board could permit continuing certification to satisfy renewal requirements. About a dozen states have done that. I don't know what's happened in Washington. Washington, I think, has passed legislation in 2018 that authorizes them to do it. I don't know whether they've actually done it. Tennessee apparently had policy to permit it, and last year decided to rescind it. So we need to talk about why that happened and what we can do about it, and what are the conditions under which it is appropriate for that kind of recognition, and what stands in the way of it. We think that the state-specific CME requirements are one of those things that stand in the way, and better alignment of those requirements, if it's possible, would be something that would be really great to talk about. So we have a lot of shared priorities with the Federation. Here they are. I won't list them for you, but I think there are a lot of things that we could be working on together. Professionalism is something that has been very much on our minds. I know it is on you, and I think together we really need to be promoting professional values in a healthcare environment that actually seems to be working against them on a daily basis. So I'll leave it there and look forward to the dialogue. Thank you.
Thank you so much for your comments, and definitely robust information that's relevant to all our boards. So we have time for comments. While you're coming to the mic, I'm going to just start out with a few. I'm going to direct this first one to Dr. Mcmahon. Do you think that board certification engagement should be considered as an acceptable surrogate for CME completion?
It depends. Some boards verify CME completion, many boards do not. Some boards have an assessment standard, some boards do not. So it's hard to make a general statement about whether board certification should be an acceptable, because there's so much variability. As Tom said, their boards are fiercely independent. Some of their assessments have become participation exercises. And open book, do it with your peers and colleagues, and don't have a summative standard to them. And some of them don't ever check continuing education completions and just rely completely on attestations. Under those circumstances, I think it's hard to say that those would be acceptable determinations in the public interest to make a determination that it's safe and appropriate to relicense that person.
So that brings us to a question for Mr. Granatier. How do we then better align the regulatory certification in education communities?
Yeah, so just to clarify, our boards do try to verify through audit attested CME, and all of our boards are expected under our standards to be able to demonstrate that their diplomates, through assessment, that their diplomates are still meeting our knowledge standards. They all do it. They do it in somewhat different ways. I would say that the answer is still it depends, because it depends on whether your expectations for renewal are satisfied by what we're doing. And we need to, I think, have a dialogue about the ways in which, if there are things in our programs that are actually not meeting your needs, are there ways that we could figure out how to make some changes in our programs that would align the content and approach to better make it possible. We think it's desirable. And there are things that stand in the way today.
Thank you. We're going to turn it to the participants at the microphones, and I'm going to go to the gentleman at the back microphone because but you can stay, front microphone, you can stay there. But sorry, I have to call you front microphone. But back microphone, can you state your name and your affiliation and go ahead with your question?
Thank you. I don't mind being called back microphone. That's just fine. Tom Lee, New York State Board. Thank you for an excellent presentation. I think it shows some innovation and the evolution of our CME system and the wonderful tracking tool that the ACCME has provided. Just two questions. Number one, CME for the physician communities are generally provided by ACCME as well as by AOA. Now, there are also many, how shall I say, sub-sponsor program, jointly sponsored program below the level of major certifying institutions. So how are those data points tracked on your data set that you have presented? Are they included? What's the percentage of compliance on that? And I'll go on to the second question is more on the return on investment and the value it provides with the CME program. Whether I think one of the prior speakers spoke to the quality process that it improves upon rather than just an hourly engagement. And I think we all want better outcome, better quality, and better quality of the data that we're reporting. So what is the additional effort to make that come to fruition? And I thank you both very much.
Thank you, back microphone. Any responses?
I can certainly take a crack at that one. We're very passionate educators. All of the accreditors and regulators are, and we recognize and value the power of education. But education exists across a big spectrum. You don't want to say, for example, that information transfer has no utility. So you want to make sure that some of those activities, if that's what the physician needs, is to learn the updates in heart failure, and the way they want to learn it is by hearing from somebody speak from a podium, you need to be able to recognize that as valuable and recognize the value of accreditation to ensure that information is balanced and scientifically accurate and commercially independent. So it's challenging to evolve entirely to an outcomes-based educational programming that's based on skill development or performance improvement, because there's huge diversity in the learning needs of our profession across all of the specialties. In terms of the variety of educational providers out there, we accredit 1,700 of them, 1,680 or so of them, and there's huge diversity on them. You saw the list up on the screen, and it's in your app in the presentation too. But all of them are required to follow those rules, and they do, because we audit them and we hold them accountable if they don't. So we track data from any of those organizations who are able to meet our standards in all of the formats that different types of organizations are able to deliver quality learning experiences, and that's what we present in the integrated data system.
And I'm sorry, is the AOA data collaborated in some way or no?
So we're in active conversations with the AOA about capturing their data. Most activities that are registered for AOA are already ACCME accredited, and many AOA previously accredited organizations are pursuing ACCME accreditation too. But all ACCME accredited organizations, whether or not they issue the AOA credit to, can use this data platform. And the jointly accredited providers too.
Thank you so much. Front microphone, you've been waiting patiently.
Thank you. I'm Scott Metzger. I'm former president with the New Jersey Medical Board. And Dr. Mcmahon, you struck a chord when you talked about the millions that have gone into opiate education and not having the desired response and outcome. We in New Jersey had a shared experience. So starting 2 years ago, thinking all this information and understanding of the lack of progress, what can be done? So we went towards redoing our regulations. And 2 years later, they should be published any day now. So my question is, understanding that there are resources and money that can be put towards this very important goal, understanding behaviors didn't change enough. We felt that changes in regulation were the next step. How do you mesh the concept of the importance of education and new and revised regulations? And thank you.
So thanks for that question. We've been part of the collaborations with the FDA and the entire community for over a decade, and it has been an incredibly frustrating journey. I think one of the core messages that each of you in this audience should be listening for, though, is that mandates in education don't work, right? That's a really uncomfortable thing to hear, but it's really important for you to hear it. I know many of you are obligated by a variety of the government and legislation to install educational mandates, but they check a box and they don't create the engagement or the performance improvements that you think they do. And in fact, they have a tendency to widely create cynicism and interfere with the ability to engage those physicians and professionals in the type of learning that's actually needed for them and is going to work. So if mandates don't work, what should we actually do? Because it's really attractive to say, well, we're doing something, and here's something where we can actually make it happen and we can see the results, right? It's really compelling to make that argument. So we've been in extensive conversations with the FDA and others to say what you need to do is find a unified way to get individualized data and work with specialty and local organizations to deliver education that's customized to helping the team and the individual perform better in the way in which they address opioids in their practice types. Obviously, the need for a neonatologist or a pathologist are very different in opioid education compared to a family physician. So all of those issues are challenging, but please stay away from general mandates. They just interfere with the ability to engage communities and make a difference in this pandemic of opioid addiction and overuse.
Thank you.
Do you mind if I comment on that too?
Please.
Well, the first comment is I completely agree with Graham. And actually we discovered ourselves and to the extent that our assessment programs can help to provide the kind of feedback, if we can target them to opioid prescribing issues or other issues related to addiction and provide feedback to people that would stimulate their learning in a way that's contextually relevant. We would like to be able to do that jointly with the CME providers. We, in 2019, created a bank of items on opioids, which were not particularly effective, and what we were told by our own boards was that they weren't sufficiently clinically specific. That this notion that physicians need to be able to see the immediate practical application of the issue to their practices. Now, I will also say, though, that practice on the question of whether CME worked or not, CME did have some effect, I believe, on prescribing patterns. Prescribing patterns have changed. They haven't solved the opioid crisis, and part of the problem is that what we were focusing on may not have been the only way in which physicians need to be educated to help solve the opioid crisis. The opioid crisis is not just about prescribing. It's also about recognizing addiction and dealing with the behavioral issues that are driving addiction. And so there may be dealing with the social determinants and other factors that affect whether people get care for their addiction. So I think there are other things I know that we are constrained by sort of legal requirements, but if we really want to think about ways in which the medical community can help to solve the issue, I think we need to look beyond prescribing education.
Yeah, I would refer you, we put out a paper, a publication through the National Academies that looked at the practice gaps of clinicians and healthcare team members, and we developed a core set of competencies that all healthcare professionals should be able to demonstrate in the care of patients with pain, inappropriate substance use and substance use disorders, which might create a great framework, but many of these now are system issues, they're less education issues, and what our clinicians are telling us is if you're multiply licensed and Wisconsin wants something and Indiana wants something and Michigan wants something, that the burden to them is overwhelming, and that the opportunity for the boards to coordinate and at least recognize reciprocity of requirements across, or have a national standard that you can meet as a clinician without having to meet all the individual member boards, would be a huge step in the right direction.
Excellent opportunity for further collaboration. We'll take the next question.
Hi, my name is Joe McGurn. I'm with InfraMed. I just want to acknowledge Graham Mcmahon and his leadership since 2015 in the area of CME, and along with Dr. Chappelle with her leadership on and combined with the joint accreditation. This has probably been the most significant period as far as improvement in CME. Again, I just want to start off by acknowledging that. So my first question is, if first Dr. McMahon and then Dr. Chappelle, Dr. McMahon, if you can give some color, if you will, to the 27 million other interactions, right, as far as, if we will, just kind of professions, not expecting exact numbers, but right, if you can kind of break that down. And then same question for Dr. Chappelle, what you're seeing under joint accreditation, and then I'll move on to question.
I'll just ask the panelists to keep your remarks to 1 minute, and then we can get the other questions in.
Thanks for that, Joe. And it's dominated, in fact, by different members of the primary healthcare team in local activities and in a variety of online activities. But primarily nursing and pharmacy dominate that mix, and it's followed by a variety of other professionals, including dentistry, but other areas like EMTs, nutrition, physical therapy, you name it, across the 24 other health professions. They're all participating in accredited continuing education. And in the best evolution there, though, has been small groups of local teams learning together, because that drives a lot of the practice improvement that we're all looking for, but dominated by nurses and pharmacists.
With medicine, so in the United States, there are 4.2 million nurses. So most interprofessional interactions occur between medicine and nursing, and PAs, but just by sheer volume of professions in the workplace, it's primarily medicine, nursing, and then pharmacy is the third.
All right, the second question is, you referred to, Dr. McMahon, in your presentation about AMA Category 1 credit kind of being the standard currency, but there are equivalencies that, both ICPE and ACCME recognize. What's evolved over time, though, is language has been included in medical practice acts, right?
Correct.
And then at board rule levels, okay, that define AMA, AOA, et cetera, equivalent credit systems. Beginning in 2010, we started to see a phrase that was started to come into medical practice acts and boards rules that said, or by an ACCME provider. So medical practice acts are much more tougher to open, okay, than board rules. But I'm wondering if each of you, Mr. Gradin also, whether or not y'all can make a commitment to provide us with a standardized phrase, okay, that can be, first of all, preferable route would be if the board has the ability to make a rule, right, regarding that, they can just simply add that phrase into the rule to recognize both ACCME providers and ICP providers. They also have a more intimate boards, also have a more intimate feel for when this Medical Practice Act is open, right? They're always aware of that. So the idea they kind of know also whether legislation is going to pass or not pass, and perhaps, you know, they can also be the vehicle to insert that. So is it possible that, you know, you three can make a commitment with kind of a sense of urgency with over the next 60, 90 days to provide that?
Yeah, so really quickly, we absolutely, we went to the Georgia Board of Pharmacy and advocated for IPCE credit to be recognized. And actually their Practice Act had CE, so it was an easy win there. They just recognized IPCE credit, but you know, to the extent that the boards can expand their practice or address this, we certainly are resources that are very happy to go to the individual boards and talk about the value of interprofessional continuing education credit.
I'm asking you to empower the boards here by giving them a template of language. If they need coaching or mentoring, they come to you. That's going to result in a much faster spread. That also provides these, you know, medical boards, right, with the opportunity to extend it out to the other boards, PT, OT, pharmacy. So that's...
Okay, I'm just gonna jump in here so you can maybe take that afterwards, because there's two questions behind you and I just want them to get a chance to get in. So,
just one comment.
No, I'm sorry, sir. But afterwards, definitely. Well, I'm so glad it's a spirited discussion. Thank you for your question. Next.
Amy Smith, American Academy of Family Physicians. Thank you all. It's great to see your faces in person. Quick question for Graham regarding your CME passport system. It's my understanding that ACCME accredited providers are required to report activity level data in your system each year, kind of sometimes retroactively, right, by the March 31st of the following year. Is the actual provider level, physician level data required to be reported by providers in real time?
Not yet, but the opportunity is that leveraging the data that all activities have to be registered in the system, and we're moving, as you know, as an accredited provider yourselves, to continuous reporting rather than end-of-year reporting will allow organizations to start anticipating upcoming activities, so you'll see all activities available and in an anticipated way in the search engine, and then linking learner completion data after that is even easier. So yes, that's hoped for, and alignment with the state licensing boards, with all of the certifying boards, to create a centralized repository will be in everyone's best interest in the long term, we hope.
What percentage would you say are reporting that physician level data today?
It's high. We have data in the system for over 450 and maybe even over 500,000 physicians already, and it's growing every day.
Thank you.
Thank you. And our final question, thank you for your patience.
Good morning. My name is Mcmahon from the Medical and Dental Council of Ghana. We have a challenge with accrediting programs for pharmaceutical companies. So when we accredit them, they go and instead of like educating the practitioners, they end up advertising their products. So I want to know what happens here. Now we have stopped accrediting pharmaceutical companies to run CPD programs, but they still collaborate with some providers, and they make like a 1-hour presentation on their drugs, and we think that instead of giving the practitioners opportunity to learn, they are advertising their product and it's not. So I want to know what happens here, how you go about it, so we can learn from it. Thank you.
Thank you.
Kathy and I could talk about this for all day, but essentially our system got started because of this problem that continuing education had become a junket and an advertisement venue for devices and pharmaceutical companies. And all of us as accreditors were set up specifically to stop this behavior happening back in the 1980s. But you have to have a variety of systems in place to make sure it stops. And we've been fortunate to bring our system in the US to a system where it has now stopped. But a couple of things have to be present. You have to have an accreditation standard that makes these types of companies ineligible for accreditation themselves. It used to be that ACCME back in the 80s accredited places like Eli Lilly, and that of course has now stopped as well. But then you also have to have requirements around who can sponsor an activity and under what circumstances they're allowed to give money. In our system, you can give money to an accredited provider, but there are absolute bulwark firewalls between being able to influence the activity. But a third part that's very prevalent in other parts of the world is for these companies to be allowed to select attendees and pay for their travel to activities or register them as a kickback for their prescribing behavior. And that is very common in many parts of the world, but absent here in the United States and in Canada. Those are the systems that we've put in place to try and protect the integrity of continuing education. They're very difficult for under-resourced countries to adopt because they've become accustomed to support from industry to build what they call their educational infrastructure. But it's highly problematic for the cost effectiveness of healthcare in those countries when they don't leverage an accredited system to ensure the independence of their programming.
Thank you so much. We went a couple minutes over, but I just want to thank everyone for their robust participation. Dr. Mcmahon, you can tell those people on the plane you were headed to the real Jazz Fest here, discussing CME trends. I want to remind everyone, please attend the AIM FSMB Spotlight Poster Session in the Preservation Hall. This special exhibition of posters highlights the work of state medical boards and researchers on topics of interest to medical regulators. As you know, there are concurrent sessions going on starting at 11 a.m., sexual boundaries and also DEI. And if you were really loving our discussion, you can come back to ours at 11 a.m. And please join me in thanking our panel and thanking the audience for your questions. And the panelists will stick around up here and you can continue discussion.